I'll be presenting a case that we did about a month ago. And it is a patient, a 63-year-old male patient who came to us with hoarseness of voice. And his CT angiogram showed this aneurysm of the arch, which was involving pretty much the whole arch from the distal margin of the innominate to beyond the subclavian. So if we were to do a endovascular repair for this procedure, the graft would have to start in the ascending aorta. There is no landing zone beyond the innominate or the carotid to get a good seal. So we planned a total arch fenestrated repair, which we have been doing in the past. So we did some measurements and we found that the ascending aorta is 39 millimeters in diameter. So we would need a graft that is about 10-15% bigger than this, so at least 42 millimeters in diameter. And we also plan to start in the ascending 6 centimeters ahead or proximal to the innominate artery. So these are the measurements we took, and this is to show that the ascending aorta was in fact even 40 millimeters in the axial sections. So we decided we would take a 42 millimeter device, and then this is how we do the planning. We look at the superior aspect of the aorta perpendicularly, and we shave off the 3 arch vessels, and so we mark them with blue circles, and we'll see the distance between them, and also with respect to that red line, which is the 12 o'clock or the superior position along the arch of the aorta. And then we transpose this relationship onto a graft, and we chose the Valiant Captivia 42-42-217. So you can see how the same relationship is transposed onto the graft, and we have 6 centimeters of graft ahead of the innominate fenestration. There are a few other things to note. One is that the subclavian fenestration has a mini cuff attached to it. This is to improve the sealing because the subclavian is bang on the aneurysm. Then there is also a looped guide wire. Here's a Roadrunner overnight guide wire, which comes from the bottom of the delivery system through the graft, loops around from the carotid to the subclavian fenestration, and goes back the same way. And then we have this radiopaque marker. It's like a figure of 8, which is attached to one of the struts in the 12 o'clock position. And when we resheath this graft, we make sure that this marker is right up on the surface. And then we orient this superiorly as we are taking the delivery system in, so that we know our clock position is correct. So that was the planning, but the problem was this, that his external iliac arteries were just 6 millimeters in diameter on both sides. And this system that we're going to use is a 25 French delivery system, which is 8.33 millimeters. So that would not fit in a 6 millimeter external iliac, and if you were to try and force it through, you would run the risk of avulsing that artery. Of course, there is an option here where you surgically create a conduit onto the common iliac artery, and then through that conduit you introduce the system. Over the last few years, we have seen a lot of TAVI procedures being done using a transcaval approach, and so we decided we will use the transcaval approach for this case. And then this is the CT scan showing the IVC relationship with the aorta. So there is a 14-degree angulation there between the IVC and the aorta, and essentially you have to puncture the wall of the IVC and the aorta and traverse that gap from IVC to aorta. So the point we selected should be free of calcium, so we marked that in with the red arrow. It's between 2 bits of calcium on the aorta, and it is roughly in the middle of the infrarenal abdominal aorta. So we want to be clear of the renals, we want to be clear of the aortic bifurcation, because we may have to actually put a covered stent there to close the hole that we're going to make, although that is the bailout option. Usually we use what is recommended is a plug. All right, so this is the aortogram. The aorta is reasonably free of atherosclerotic plaque, but there are those calcific lumps there. And the point we selected, you can see there's some calcium above and below it that's marked in the red arrow. So this patient had a renal artery stenosis. So the first thing we did was to fix that. We put a stent. And then this is how we do the puncture from the IVC to the aorta. So we have, this is an Agilis sheath, and through that we have a CXI catheter, inside which we have a microcatheter, and inside which we have a O14 Astato wire, and that's the soft tip of that wire. And we advance that wire towards the aorta, and we mark our target with a snare, and we look at it in orthogonal views. And in the lateral view, you should be aiming for the middle of that loop. So that's the view on the right side. So we don't just use force, we actually connect this system to an electrosurgery pencil. So that wire is attached to this electrosurgery pencil and on the outside. And we have a circuit established. So when we switch this on, we can very gently and accurately advance the wire, and it will burn its way through the wall of the IVC and the aorta and reach the lumen of the aorta. So this is that actual process going on. We are advancing the wire. So it is done very gently and slowly, and you have to be sure that you are reaching the target. And then on the other side, you can do a test shot and make sure that the wire has entered the lumen of the aorta. Once you're sure it's there, you close the snare loop, and then we actually push it up rather than pull it out. So as we push it up, we are feeding the wire also from the venous side, and the loop goes right up to the aortic arch, or high up in the descending aorta. And then over this wire, we advance the microcatheter and then the CXI catheter. And then once the CXI catheter is well in, we remove the wire and the microcatheter and switch over to a stiff wire. And so that's the stiff wire is in, and now we are trying to advance an Agilis sheath, a 7 French sheath, through the wall of the aorta. And you can see that you do have to use a little bit of manipulation to get through. And then subsequently, we put a 14 French dilator. And then there is a theory that the pressure in the retroperitoneum is lower than the pressure in the IVC. So if you have a hole from the IVC to the aorta, the bleeding will occur into the IVC. It will not spread in the retroperitoneum. So that's the theory. We wanted to put that into a test. So we did an angiogram after making a 14 French hole, and you can see that theory is correct. So the contrast moves directly from the aorta into the IVC, and it does not spread in the retroperitoneum. So that's a remarkably fortunate quirk of physiology, because this helps us a lot, because when we are doing exchanges, we are not bleeding in the retroperitoneum. So as long as the IVC hole is patent, the blood will all just go into the IVC, and you have something like a AV fistula. So then we put a bigger sheath in, and then finally we brought the delivery system in, which was 25 French. And then we did everything else as usual. So here we have deployed the endograft in the arch, and then we have cannulated the innominate fenestration, and we have deployed, we created a wire loop from the brachial to the femoral, and over that we are deploying a fluency stent, which we are dilating with a balloon just to iron it out. Then we did the left common carotid, and then finally we did the left subclavian. So this is the left subclavian fenestration stent being balloon dilated. You can see that we have 3 wires going through the 3 fenestrations, and all 3 are exteriorized. And all these are hydrophilic O1, O35 Terumo wires. So they're not stiff wires, but you get the support because you have got control on both ends of these wires. So we have a 4 French sheath in both brachial arteries and the left carotid artery. So these 4 French sheaths don't create much trouble. At the end of the case, you just remove them and you get hemostasis. So you don't need closure devices. So here we have deployed all the 3 stents, and that's the end of the procedure. And so this was the final angiogram. You can see the aneurysm is excluded. The 3 arch vessels are flowing. The repair actually starts way down in the ascending. The free flow has actually reached the ST junction on the inner curve, and distally we are well past the aneurysm. So then we have to what do we do with that aortocable fistula that we have created? So it is recommended that you put a duct occluder. So through the Agilis sheath, we brought a duct occluder, which is slightly bigger than here it's, I think, a 10-8 duct occluder. But here we realized one thing, that when we were taking the delivery system of the aortic endograft out, we had failed to reunite the nose cone with the sheath. And the sheath actually reached the IVC before we realized that. So we had to pull the nose cone through, and the back end of the nose cone is not smooth. So it actually enlarged that orifice in the infrarenal aorta. And I left a wire there just to know where that orifice is. In case this whole thing falls out, I can go back in. And when we did an angiogram, you can actually see that that orifice is bigger than the plug that we're going to use. So we realized this plug is not going to work. So we went to a bailout option, which was putting a covered stent. And this is the covered stent. It's an Endurant iliac limb, which is 8 centimeters, and it fitted perfectly in the infrarenal aorta. And you can see a little bit of blush of contrast through this, but that is graft porosity, which will settle down quickly. So that was the completion of the access closure. And so this is the comparison of the baseline to the end, and this would have otherwise required a surgical conduit, which is quite a procedure because the patient has to be operated on before and after, and it's quite a painful thing to have a conduit created. So this is, I think, a very exciting advance in TEVAR, and which we hope to use more in the future. Thank you for your attention.
Superb case, excellent case, complete actually arch of aorta aneurysm completely repaired through this, and with that fenestration to all the arch vessels. Superb, excellent.
Judge, very nice case. Transcaval approach has been described in many cases in TAVI cases, but I think it's not done with device for EVR. This approach, I think this is, as you described earlier in any of these cases.
Yeah, this is the standard approach. There is a review in JACC this January on how to do transcaval access by Lederle, and he recommends actually to start with a plug and see if that works. If that doesn't work, then bail out with a covered stent. But you should always have a covered stent ready as a bailout, because that's your way to go in case your plug doesn't work. If the plug works, that's great. Now, there are a few cases where they just left it open, and what happens is there is this fistula, but over time it just reduces in size and closes off. And it doesn't create too much of a hemodynamic problem. In very few cases, there is a little bit of hypotension, but patient generally remains stable even if you didn't close that rent.